My name is Richard Kajimu. I coordinate the webinars on behalf of the Safe Motherhood Expert Committee, that is NASMEC, which is working together with the Mulago Specialized Women and Neonatal Hospital and the Ministry of Health to host this webinar on prematurity. And Dr. Dale will be giving us a bit of that detail. So I just want to, the panelists, you have access to 2 chats. You are able to comment in the chat where everyone participating in this webinar is able to see your comments, as well as all the participants. You can send comments within the chat section. There is a Q&A section. Please, if you have any question to any of the participants, I mean the panelists, post it in the Q&A so that they can see it and respond to it directly. I will allow a few discussions at the end, and I'll unmute the participants that will have raised their hands to contribute. At the moment, we are all muted and only the panelists are able to speak to the audience. Otherwise, thank you so much for joining us in the commemoration of the World Prematurity Day. And I would like to hand over to Dr. Deo Munube, who is the President, Uganda Pediatric Association, the moderator for this afternoon webinar. Thank you. Over.
Thank you, Richard. Good afternoon to you, ladies and gentlemen, and welcome to this commemoration of the World Prematurity Day webinar. It is my pleasure and honor to be able to moderate the session. I will just share a few highlights and then call upon the next speakers. Okay, so good afternoon again. And why are we commemorating the World Prematurity Day? This is a day which is marked on the 17th of November every year to raise awareness of the challenges and burden of preterm birth globally. It is important to note that this is one of the new days that is commemorated, just started over 10 years ago, and really as a result of the high burden of prematurity. As you will see in the presentations, 1 out of every 10 babies that are born preterm, or as we use the term, are born too soon. And the theme for this year is zero separation. We are aware of all the benefits of keeping the mother and baby together, but it's something that we have to keep re-emphasizing. So it is zero separation. Let us act now. We must keep the parents and babies born too soon together. And it's important to note that they have said the parents are not just the mothers, because we have to involve both the mother and the father when it comes to caring for this preterm, because it's a long-term journey which cannot involve just one partner. As I'd mentioned earlier, 1 in 10 babies are born premature. And for us to be able to improve the outcomes, we must be able to know these statistics. We must be able to know why it occurs. And several of the speakers today are going to highlight on some of these key aspects. At this juncture, I'm going to call upon Dr. Dale Migadde from the Ministry of Health to give us the current status in preterm care. Dr. Dale, you're welcome. I'm going to remove my screen now. Dr. Dale, you're welcome. Please begin your presentation.
Sorry, Dr. Deo Munube, we have Dr. Evelyn Nabonye online, who was supposed to give opening remarks and welcome us on behalf of the Women and Neonatal Hospital. Yeah.
Sorry, my apologies. Dr. Evelyn Nabonye, you're please welcome to give your opening remarks.
Thank you very much, Dr. Deo Munube. I wish to take this opportunity to thank you for allowing me to make this small presentation. So as we are aware, the World Premature Day is celebrated every year on the 17th of November. And the theme, as has already been mentioned, is Zero Separation, Act Now, Keep Parents and Babies Born Too Soon Together. According to the World Health Organization, preterm birth is the birth of a baby before 37 weeks of gestation. Each year, 15 million infants are born preterm globally, with 1 million of these dying due to prematurity. Sadly, over 60% of the preterm births occur in Africa and South Asia. Preterm birth and its complications are the largest contributors to infant death globally and in Uganda as well. Uganda currently ranks 28th worldwide in preterm births, with an estimated 13.6 per 1,000 live births. Approximately 226,000 babies are born too soon every year. And of these, 12,500 children under 5 die due to preterm complications. So in Uganda, prematurity contributes 27.9% of neonatal mortality. And this is second to birth asphyxia. The Ministry of Health has put in place several measures to reverse this trend. One of them is putting in place a national newborn steering committee, which comprises of health professionals and development partners that are able to support the implementation of high impact interventions in Uganda. Also, newborn care units in health facilities have been established in Kampala and in surrounding areas. We are also aware about the ongoing neonatology fellowship and critical care training, which are aimed at building capacity and on-site mentoring of health workers, also providing managerial and clinical skills in core competencies for the management of sick and small newborn among the frontline health care workers. So this training measure also addresses the challenge of human resource to work in the newborn care units that have been set up. The World Prematurity Day is an important time to focus global attention on the burden of preterm birth, leading to long-term morbidity and infant mortality. It is also an opportunity to pay attention to the heavy burden that preterm birth causes on parents, families, and on former preterm born children. Among those are also health workers. On the 17th of November, therefore, we show compassion and support for families who are experiencing the anxiety of premature births by observing the World Prematurity Day. World Prematurity Day therefore reminds us of babies born too early and the health challenges that they can face as they grow up. In order to raise further awareness about the challenges of preterm birth, the National Organizing Committee at the Ministry of Health has organized this webinar, which is taking place today, 15th November 2021. And as Mulago Specialized Women and Neonatal Hospital, we are privileged and honored to have been delegated to host this webinar. As you may be aware, the hospital, that is Mulago Specialized Women and Neonatal Hospital, was officially opened in October 2018 with a mandate of providing specialized and super specialized reproductive and neonatal health care. This is in line with the NDP3 and the Human Capital Development Program objectives. Over the last 3 years, we've seen the hospital showing steady growth in terms of the number of clients seen, including in the Nicu, and also in terms of acquisition of more specialized equipment and human resource for the different units. And this has enabled the much needed specialized quality care, including the neonatal care. The neonatal intensive care unit in Mulago Specialized Women and Neonatal Hospital provides provides care for a variety of conditions for our babies, and it is a 4-level unit. So this offers care up to the highest level of neonatal intensive care unit, caring for the most complex and critically ill newborns. It has modern equipment that handles all kinds of complicated newborn illnesses. It is a 63-bed capacity unit, 45 of which are Nicu beds and 18 are kangaroo care beds. I must say that this is one of the busiest units in the hospital, with up to 100% bed occupancy during the last year. We have successfully taken care of preterm babies, including those who were born as early as 24 weeks. And we have a number of them who are not only surviving, but are also thriving well with good developmental milestones. I'm glad to let you know that the Neonatal Intensive Care Unit at Mulago Specialized Women and Neonatal Hospital is one of the training sites for the Neonatology Fellowship Program of Mccary University. We are privileged to have 3 of our pediatricians on this program. This training has greatly improved neonatal care services within the hospital, and I believe in the country as well. We are therefore committed to providing the best reproductive and neonatal care, not only at national level, but in the region and beyond. As the theme for World Prematurity Day for this year goes, Zero Separation, Act Now, Keep Parents and Babies Born Too Soon Together. We are committed to providing the best environment for both the parents and the babies to thrive, such as having sufficient space dedicated to kangaroo care. So this is an opportunity for us to be able to interact, and I hereby declare this webinar open and wish you all fruitful deliberations for God and my country. Thank you. Thank you.
Thank you very much, Dr. Nabunya, the Director of the Mulago Specialized Women and Neonatal Hospital, for the remarks. We will go straight into the webinar, and I would like to welcome Dr. Dale Migadde from the Ministry of Health to give us the current status in preterm care. Dr. Migadde, you are welcome. Thank you. Over to you.
Yes, good afternoon, everyone. I'm going to present the current status of preterm care in Uganda. Yes, and the brief background we have on this, we know that more than 1 in 10 babies are born around the world, are born prematurely, and over 80% of the preterm births globally are in Sub-Saharan Africa and South Asia. We also know that prematurity is one of the leading causes of death globally for children under 5 years. In Uganda, approximately 100,000 babies are born too early, and around 9,830 children under 5 die due to direct preterm complications. Our current neonatal mortality rate stands at 27 deaths per 1,000 live births, and this rate has slowly been decreasing over the past 15 years. Uganda is committed to having this number to 15 as set by the SDGs by 2030. And we know that in order to realize these national targets, we need to improve the overall health status of the prematures. Based on this, the Ministry of Health, working closely with its partners, has put up strategies to improve the newborn outcomes in the country through the different approaches, which are summarized in 4 different categories. Number 1, development of and updating newborn policy strategies. Guidelines and the capacity of the National Newborn Steering Committee to improve the coordination and governance of newborn care across the health sector. And number 4, conduct capacity building of health workers to deliver newborn care packages at all levels of care. So what we've done so far in regards to the policies and strategies, we have adapted the WHO quality of care standards for the small and sick newborn, and also adapted the national guidance on management of newborn sepsis where referral is not possible, and incorporating it into the IMNCI chart booklet and ICCM Sick Young Job Aid. We are in the process of developing the revised KMC implementation guidelines, and we have also updated the essential maternal and newborn clinical care protocols and guidelines. So this has enabled us to do KMC facility assessment to assess for the readiness of these facilities to implement kangaroo mother care. We have done a national dissemination of management of newborns where referral is not possible. So we also continue to do, we did a webinar on integrating the WHO evidence on early initiation of KMC in the unstable preterm babies. So the other avenues where we are rolling out these policies and guidelines and like a commemoration event, the World Prematurity Day, and the scientific webinars like the one we are having. The other strategy we are using is to strengthen the capacity of the National Newborn Steering Committee to improve the coordination and governance of newborn care across the health sector, and also coordinating the different partners that are implementing newborn work in the different regions. So in terms of capacity building of health workers to deliver newborn care packages at the different levels, with support from AMCHIP, where Ministry of Health is supporting the fellowship program for neonatology, where we are targeting pediatricians and also some neonatal nurses. We have also rolled out integrated clinical mentorship program, including the newborn care across all regions. And also through AMCHIP, we have procured newborn equipment. Still with support from partners, there's been establishment of NICUs in different hospitals, both at the national level and the districts. For example, the one in Kasese, Kamuli, Kawempe, and also Mulago Men's Hospital. We have conducted integrated support supervision visits still to the different regions, with also focus on newborn care. So shall look at the performance of selected indicators in the management of newborns for this last financial year. We know that complications due to prematurity among the leading causes of death in newborns, only second to birth asphyxia over the last 3 financial years. And birth asphyxia has remained the leading cause. However, prematurity comes in second, and septicemia, third cause of death. And if you look at this data here, we know that it looks at the early neonatal mortality rate per 1,000 live births from January to June. Yeah, and note it has fluctuating between 4 to 6.4 in the different months. So this data here, we are looking at the early neonatal mortality by district, and you can see that those dark districts have neonatal mortality, early neonatal mortality of 10 and above from January to March. You can look at districts like Moroto, Masaka, Mubende, Chivale, having among the highest neonatal mortality. Then still the same districts almost like Masaka, still between April and June 2021 had the highest neonatal mortality. Then we look at the instance of low birth weight among newborns. Yeah, and so this is the percentage of the low birth weights among the babies who are born. And we can note that in the financial 2021, there was a slight decline in the number of low birth weight babies to 5.4 of the live babies by the end of the year. So from July 20, it was at 5.8 around August 2020, And by June 2021, the number had gone down to 5.4. Then still this graph down here looks at the incidence of low birth weight among newborns by region. And it's important to note that Karamoja region has the highest number of low birth weight babies, closely followed by Kampala, Acholi, and it's Kampala, Acholi, yes. So we look at the low birth weight babies who are initiated on kangaroo mother care for the different months and also the different regions. So for the months, we note that around January 2021, we had the lowest percentage of babies who are initiated on KMC. However, when we go down to the regions, we can see that Kampala has the highest number of low birth weights that are initiated on KMC, 83.5, and Bugisu has the lowest, and Bugisu and South Central have the lowest number of babies who are initiated on KMC. So again, looking at KMC coverage by district, we can clearly see that the districts in Acholi and the Southwest have the highest coverage of over 80%. However, some districts which have less than 50%, including some in West Nile, Kotido, Abim, yes, and others in Central. So this, we're looking at the number of live babies who have been resuscitated over the last financial year. And this figure was around 61,961 babies. And we had the highest number in September 2020. So we look at breastfeed, percentage of children who are breastfed within 1 hour by district and also by month. So the percentage of mothers who initiated breastfeeding after delivery has been high, with the lowest percentage recorded being 90.3, that is June 2021. However, by region, still Teso has the highest number, 97.4%, whereas Kampala has the lowest number of mothers who, percentage of mothers who initiate on breastfeeding at 83.1%. Still, this we are still looking at the percentage of children who are breastfed within 1 hour. Yes, and you can see Kampala there clearly, and Nakasika and Mubende having less than 80%. Yes, thank you very much. I'd like to acknowledge you, Said MCHN, the team we have worked with to come up with this presentation. Thank you. Back to you, Chair.
Thank you, Dr. Migadde, for giving us that succinct summary of the statistics. And very important to note is the increase in the percentage of children who are initiated on kangaroo mother care. That is very important to note that although we have an average of 60%, however, some places are pushing as high as 84%. At this juncture, it will be my honor and pleasure to welcome Dr. Margaret Nakakeeto, the chair of the Newborn Steering Committee, to give her presentation on preparing health systems for preterm care. Dr. Nakakeeto, you are welcome. Thank you.
Thank you very much, everybody. I hope you can hear me. I welcome everybody who is at this webinar. I don't know whether the moderator has said it right. I thought that I was supposed to discuss home to hospital or home to a health facility. That's how I'm going to describe. Maybe that one will lead to helping the health systems. What I'm going to say this afternoon, I'm basing it on the Newborn Steering Committee work in Acholi, West Nile, Busoga region, Kamulia and Buyende, the East Tororo and Busia, Renzori region, Kasese, Singiro, and the Kikuwe districts. These are some of the districts which the newborn steering committee has been supported either to functionalize or establish newborn care units at facilities, regional hospitals, district hospitals, and a number of health center FORs. Next slide. In Uganda, we will realize that we have the proof and we have the facts on newborn care, health service delivery. And we have a long journey to make. However, most of the stakeholders are detached or blinded from the reality of why this is so. The facts are always given, as you have heard in the first presentations. We have the proof, but the reality is sometimes different on the ground. What is the dilemma for mothers? We are talking about hospital, from home to hospital. A mother deciding to come from her home to go to a hospital. We realize that families are not given the opportunity to make a choice because it is either the health facility nearest to you. Most of the time, they don't even know what is being offered at that facility. So instead, they are left to no option but to attend to that facility which is near to them, even though they don't know whether the service they require is there or not. And mothers in this country do not even know what to expect in terms of service delivery. For example, I don't think the mothers know what their antenatal package is. I don't know whether they know even what, let's say you go to a lab and you know that if they didn't do this test, I can demand for it, because they don't know what is supposed to be done. At every point, be it ANC, be it delivery, be it postnatal care, be it neonatal care. So they don't have the information. So how will they leave their home saying, I'm going to this facility or that facility or the other facility? If something, if they knew what to expect and why they would be looking for the services, regardless of where they are. That is where this leads us to the next slide. So I mean, if I know what I'm expecting at that services point of delivery, then I will know how to make my choice to go. So one question I ask, because most of the time they're saying how many mothers or how many families are within 5 kilometers. To me, I'm saying, is distance the key determinant factor for ANC or institutional deliveries? And I think the answer is no. Why do I say that? The reality is that we are wrong in that statement. People travel from up country to Kampala seeking for care. Others even go ahead to go abroad for good services. This shows that people are willing to spend all they have to stay alive and healthy. So this business of saying we are too far, we are what? I think it is the system which is the problem. It is the infrastructure. It is the service availability. If those services are available at all levels, at any level, at the highest level, and everything to care for the newborn is there, and people are informed, they are told where the services are, they know what they expect, I think they would attend to those services and they would go an extra mile to go and seek for those services. So distance is not top priority, but rather the system issues. Next slide, please. So if I were a mother, I'm talking this if I was a mother, and I'm looking for quality services for newborn care in this country, these are some of the questions I would ask myself. If I'm going to go to a facility, do the service packages, are they good enough for myself and my baby? I would say is the infrastructure and availability of equipment at any facility, is it available for my baby? Is it available for myself? I would say, do the health workers in that facility have the knowledge and the skills to attend to me and my baby? And if that is so, are those facilities, if I had any problem, if I had a complication, can the health workers take care of it at that level, at that facility? The next one, I would say friendliness and hospitality at that facility. We know we have an indicator which says experience of care, and it has been very difficult for any mother to say that when they come to our health facilities, be it private, be it what, that they can say that they experienced good quality care. And I believe that as the system, as we move on ahead, we have to see that some of the infrastructural things which I can talk about here, you go to a health facility and you cannot even use a toilet because the toilets are really filthy. Even as the health workers who visit those health facilities deep down there at health center 3, health center 4, I mean, you don't take your breakfast because you don't know whether you will have anywhere to go. And all that is a friendly and environment. And also the staff working in that facility, behaving professionally, dressing professionally, having a smile on their faces, and later on being knowledgeable even to inform the mothers of what is expected when they are at their facilities. So distance from my home and the referral system, I usually ask myself, if I was a mother, if I went to this facility and I'm referred, will I have the means to go there? Will I have the, will my baby survive the distances that I tested? Just a few weeks ago, I was doing mentorship in West Nile, and moving from Omugo Health Center, we had to go to Rhino Camp Health Center 4, and it is 93 kilometers on a rugged road. So if I was to refer a baby, and from Arua to Omugo was also around 94 kilometers, and it is a Maram road, it had rained, it was slippery, some places had flooded. So you can imagine if a baby is being referred from Omugo to Arua Regional Referral Hospital, that baby will just definitely die on the way. So how can the mother walk from home? She will say, anyway, my baby will die on the way, or this and this will happen. So we call upon the planners to do something. Next slide, please, Richard. So in conclusion, and the next steps, we want to say that mothers and newborns at the mercy of the poor health system. I'm sorry to say that. I don't know whether tonight I will be in my bed peacefully. But quality, the next step, we want to say that quality preparedness of the supply end is key. The people, we who are giving the skills, the equipment availability, and the infrastructure, they all have to be dealt with. That's why I said in the beginning, we have a journey to make. And mothers and families are key partners in newborn care. Therefore, they should be given timely information, and they should know all the information. And while we are planning, they should be involved, not for us to sit where we are, because how did I get to know all this? Because you go there and you interact with the families, you interact with the health, with the community, and strengthen community-based newborn care. This one, we all have to get into it together. Thank you very much. And I say thank you to all the partners who have assisted the newborn care, the steering committee, to implement newborn healthcare services in this country. Thank you very much.
Thank you very much, Dr. Nakakeeto, for the talk from home to facility. And I think it has been able to pave way to see how we can improve the health systems to prepare for preterm care. And important from your talk has been distance is not a key factor for antenatal. Information to the mothers is very key. The experience that they have as they deliver is a key factor to improve the outcomes. Thank you very much. I shall now move on to invite Dr. Flavia Namiiro to share her presentation and give her talk on innovations and technology in the digital era, care for the preterm baby. Dr. Namiiro, you are welcome.
Thank you very much, Dr. Deo. Yeah, as ably introduced, I'm Dr. Flavia Namiiro, Pediatrician from Mulago Specialized Women's Hospital based in the Nicu. And as you can see, I'm discussing innovation and technology in the digital era for the care of the newborn. And this is also with other collaborations. The main purpose of this presentation is really to stimulate us to do something, irrespective of our background, expertise, experience, or skills, are either as others at our workplace. I know we can all do something. I'm here by showcasing projects, innovations, and collaborations which have potential to reach many more babies wherever they are born, whether in a rural facility or in an urban facility. If we are talking of best approaches, which can only be reproduced or applicable in just one region of the country, then I think we lose it. And I really thank Dr. Margaret for setting the stage. So mine is really an advocacy, awareness, and a call on many of us to join from wherever we are for the cause of strengthening community support and health service delivery to reach many of the babies that are born preterm. We are aware of the inequity in health, and the preterm babies are not spared, especially in the rural areas, the urban slum environments. We have seen the statistics from Dr. Deo's presentation. A bigger part of these babies are actually within Kampala. I definitely have a disclaimer to this presentation. I'm only sharing information, and I think the work that is done by some of the projects that I'm showcasing can be reproduced. And I think technology is one of those noble, all underutilized fields that can help us reach many more babies in the country. So number one is the PRISMS, which is protecting infants remotely by SMS. It is Mbarara University Science of Technology led project and supported by CHAI and World Technologies. And the focus is mainly on the challenge of neonatal clinical care decisions for many healthcare providers. I really feel that if this technology, which is currently in its final stages to approval and implementation, currently it's only in a few districts, is well distributed, we can help health workers even in the remotest parts of the country. It has been developed to provide instant clinical care decisions. So wherever a healthcare person is and they are stuck or stranded with a baby, they don't know what to do, they can be helped to actually manage this baby. Secondly, it's also to provide continuous newborn care education. And thirdly, to provide surveillance data for health planning and quality improvement. Much of this has also already been talked about by Dr. Deo. The other project is the Mccary University Biomedical Engineering Department, which has been around for the last 10 years and has contributed and made impact to the healthcare delivery in Uganda. For us who are sharing the hill with this department, have had an opportunity to have our equipment repaired and serviced in the NICU. However, one setback is actually getting the spare parts sometimes. This can be overcome if our own inventors and engineers are supported to actually be a part of, innovate this equipment and are regularly there to take care of them. This can also reduce to the wastage of the many equipments that are stored away because they cannot be repaired, they cannot be serviced on time. But we know that these teams are actually getting out. We need to give them jobs and then they can benefit us in the health service delivery. Recently is the 10 baby incubator, which is currently installed at Kawempe National Referral Hospital. For me, this is one of the biggest innovations of the century. It has up-to-date technology. It's a multi-purpose system providing warmth, respiratory support modalities like CPAP, provision for therapeutic cooling, phototherapy, continuous monitoring of the babies, just to mention but a few. And this has been locally made. To date, it has won the global and national awards. But despite all that work and effort that has been put there, people still have different views, especially the users. Personally, I think when it comes to space, this is a unit that can be installed in every part of Uganda. And every referral hospital can have this because you need a little space to actually accommodate 10 very small babies, as opposed to having to move babies more than 300 kilometers to actually seek care where they think it is found. When we look at the power, one may worry about the amount of power that this unit is going to use, but you actually learn from the innovators that it doesn't need a lot of power. So probably we should first understand how things work, pick interest in the technology before we actually rub off things thinking they're actually complex. There are other collaborations. Many times when I encounter a preterm baby for the first time, I usually tell them to pray that their parents love them, because prematurity and abandonment, you find that a baby born preterm is at a higher risk of being abandoned as compared to a baby that is born term. So we have had collaborations with homes like Sanyu Babies Home, Baby Watoto, and Zambia Babies Home. Not that I am saying we have many more babies home so that people abandon them, but these homes have been available. They've been handy in helping provide homes and food and support for these babies, especially when they have grown and they have nowhere to go. Another foundation is GEM, which has supported children with special needs. And I thought we need to acknowledge people that are contributing in one way or another to ensure that things are done well for babies. Something special about this foundation is it is not just about helping the mothers find care for their babies, link them to hospitals, but they go an extra mile to actually let the mothers know that when good care is given to the babies, they can also make it in life. And they've restored hope for these babies. ATA breast milk community is another one. We're about to hear more about what ATA does, but we find that mothers that have delivered preterms oftentimes have issues having enough breast milk for their babies. ATA has been very handy in supporting such mothers. Some mothers are just stressed at the mere fact of having a preterm baby, and this still affects their breast milk production. And the mothers that end up with multiple babies are still in the same, face the same problem of having enough breast milk for their babies. So we really thank us partnering with ATA and supporting some of these mothers. Another foundation that we have really collaborated with is Mama Turia Foundation, which extends support for mothers from mothers. One of the biggest challenges that we have found taking care of mothers and babies that have had preterm babies is being abandoned in hospital. And this is what the fathers say: we don't deliver such babies. Like their family is too unique to have preterms, but usually we tell them nobody signs up to have a preterm baby. So mothers go home and they are on their own. They have to support themselves and their babies. And Mama Turia has been very handy But this is only in Mccary division. This is something that we can actually have in all parts of the country. We can all, wherever you are, you can go and learn from what Mama Turia is done. You can start with your small community and actually make a difference in someone's life. It's not about resources, but it's about the heart. And the time to act is now. Last but not least is the Uganda Police through the Child Protection Unit and with our social workers, we have had an opportunity to actually reconcile families. So in summary, what am I saying? This is the .com era. Our children understand digital language. So if we are still analog, we are about to be left behind. We need to have a mindset change, learn, but also utilize the personnel that have been trained in engineering. And we need to work with each other. I think gone are the days when you think you're a doctor and you're going to do everything. I may know how to treat a human body, but not necessarily the machine. So when I mess them up, they're bound to be spoiled for forever. There's need for us to embrace technology, as I earlier mentioned, that this is a novel field that we have not fully utilized in the health sector, both for the pre and in-service people who are coming in to offer service in health. And telemedicine is here. If we can treat patients from different globes, if this health happens globally, then it can also happen countrywide. Some of these projects we can actually use. We can reproduce, we can apply in various parts of the country. And lastly, care for the preterm is much more than just at the facility and the home. A lot more goes on in the community and we need everyone on board. And the time to act is now. Thank you very much for listening, for God and my country.
Thank you very much, Dr. Flavia, for bringing in the innovation and technology. As you have highlighted, the inequity in health affects everyone, even the preterm baby. I must applaud all the innovations that are being made. But what is also important as we think of innovation and technology is how can we interface with artificial intelligence, for example, in using the 10-baby incubator. Those are some questions which we can always think of. At this juncture, I'm going to invite Professor Peter Waiswa. He is a professor in the School of Public Health, and he'll be giving his talk on policy and program implications for community care. Peter, you're welcome.
Thank you so much. Can you hear me?
Very well, so thank you.
So I'm going to be speaking about from home, from hospital to home, what are some of the policy and program implications for bridging the gap in care. And I'll be giving a couple of case studies to support this work. Or whatever I'm going to present comes from our research on newborn health. So mainly. And in terms of the objectives of the presentation, we want us to understand the challenges and opportunities in bridging the gap and give recommendation on the way forward. One statement I can make, as you might know, there was a recent sort of policy changing paper and good enough on the WHO Global Advisory Group to the Director General. We are making recommendations for doing kangaroo mother care everywhere, at home, in the community, and in the facilities. So from home to facility, and from facility back to home. I think that is a key take home message that we should be aware of. And I'm going to be using a couple of case studies. The first I'm going to start with is work done by Doris Kwesiga and others, and myself in the Eastern Uganda, then a couple of other case studies. So in this case study, we wanted to understand what happens when you discharge babies to the community. And we used qualitative studies in 5 districts in Eastern Uganda, but also in hospitals, a lot of interviews and also engagements. And what do we find as the key findings of transition to home? One, issues of cultural and traditional issues are predominant. There are a lot of harmful care practices for preterms. The use of charcoal stoves still continues despite our teaching of chemistry. The use of hot cans of water for warmth. The lot of gender roles where women are expected to continue their regular work. Remember, most babies have a lot of, most mothers have a lot of children, but also they do a lot of work. So things like continuing kangaroo mother care at home becomes a challenge. That leads to reduced financial productivity because they have to attend to babies. For a long time. Many of you are pediatricians and nurses. You know that care for a preterm takes a long time, even after discharge from hospital. There are a lot of non-community follow-ups. There is not follow-up. We don't have a system for follow-up of babies at home in this country. So sick babies at home are faced with so many challenges of access to care. Including physical, financial, and those of perceived challenges Dr. Nakakeeto has talked about. There is lack of support for mothers during kangaroo mother care and even chemistry can be seen as perceived as difficult to do. That is what many mothers are saying, that when you put a baby in the chest for a long time, it can be tiring. But also there are issues of stigma and demotivation from the community. He's carrying a baby who is too small. One person said the baby is like a rat, the size of a rat, about a small preterm baby. And there are a lot of myths about what caused actually this preterm. There are a lot of maternal mental issues that women go through. Issues of stress, depression, discouragement, and yet they are not supported to overcome them. Even within the hospital, this is rarely attended to. There is limited knowledge of kangaroo mother care among mothers, even among community members and family members. And this acceptability, although it's improving, needs to be attended to. By the way, most mothers, when they have a preterm, they are not prepared to have a baby. So, they don't expect that they will give birth to a preterm because they're expecting the baby will come at 9 months. But the baby comes all of a sudden when we have not prepared them at all. How can we have such a high prevalence of preterm baby as presented earlier? And we're not integrating this in our antenatal care to tell mothers that you have a risk of getting a preterm so that just in case it comes, this is what you need to do. The second case study was done by a student of ours called Ziada, who looked at the cost of care for babies in hospital. And I'll give one result among so many. She found that even in these hospitals, which are public hospitals, which are perceived free, families spend up to almost $150 directly in the care of the baby, or what they forego. Remember, there are so many costs the hospital doesn't meet. This is about 500,000 that they meet. But of course, if you go to a private hospital, you can incur millions. One doctor said on Saturday on Radio 1 that it can be even up to 100 million shillings. So it is a costly issue. In case study number 3 from my PhD student, or our PhD student, Dr. Gertrude Ahumusa, has been looking at what are the neurodevelopmental issues and other complications at population level. And she finds that when she compared babies who are born normal weight and at term compared to preterm, preterms had almost a 19%, you could even say 20, chance of, in terms of proportion of those who had malnutrition, compared to just 2% among those who are born normal weight or who are born term. So prematurity exposes babies to having to become malnourished. And the severe malnutrition was actually almost 6%. whereas among those who are born at term, there was no case of severe malnutrition. So how are we dealing with issues of feeding after discharge? And then in terms of neurodevelopment disability, of course, disability is a range from things in the social aspects to other more severe complications. But taken generally, there was a high prevalence of and incidence of neurodevelopmental disability among infants in this cohort, about 12.7% prevalence, and the incidence was like 20%. Most of the disability were in the social aspects, like babies later, they don't interact so much with others, but there are those who had severe disabilities. So how do we prepare for long-term complications? And then from our work on the preterm birth initiative, which was a trial in Uganda and Kenya, this study had 4 components in Uganda and Kenya. We had data strengthening, we had the use of modified safe child checklist, we had quality improvement collaboratives, and we had a simulation training and mentorship. A lot of pediatricians and obstetricians supported us in this work. I'm going to pull out one result. The package led to a lot of improvements. So an intrapartum package, a comprehensive package, can make a lot of changes, can improve results in terms of preterm who are fresh, stillbirths can be reduced, pre-discharge mortality can be reduced. But I wanted to attend to this one. Neonatal mortality for preterms at 28 days was reduced by this package. So the point is, when you start newborn care, preterm care in the facility, and you do it well, it can have implications even beyond facilities. In other words, start preparing preterm care in the community is successful if it is well done in the facility. That is the key message. Prepare mothers for discharge, and then they'll continue actually. And the impact can continue beyond hospital. This was also found out by the study by WHO, that the care that you provide can actually go further. And I'm doing some work with a group called Adala. I'm actually on their, one of their board members, and Adala and Choko Hospital. In fact, for this group, we have engaged, I want to do a commercial here, we've engaged to develop a comprehensive package that we want to move from Choko to about 5 regions in Uganda in the next 5 years. And we are mobilizing resources to work with them and the government so that the Choko model is actually taken to the rest of the country. So it's quite exciting. And we are doing a study there, which is called the Choko Facilitated Home Project. And in this work, this is the Choko Hospital that some of you know. We have a package in the hospital in terms of care and preparation for discharge. The mothers or families are supported in terms of breastfeeding. They are educated. They actually, brain development is done, and they also taught how to stimulate their babies. And then most importantly, we've linked in community volunteers or our VXTs. So we've trained VXTs, one to refer mothers or preterms at hospital, but also from hospital to receive the baby. So when the baby is when the mother is discharged with the baby, then the VXT is informed, and the VXT immediately makes a home visit to the family of the preterm. And among the things that the VXT does weighing, assesses the baby's temperature, does education of the family about the care of the baby, so that this is continuous. And we have actually published a protocol for this work, and also we are going to publish results. But some of the results that we are seeing is that this package actually improves breastfeeding significantly, improves infant growth, improves neurodevelopmental outcomes, and also improves vaccination and gives the family hope. I'm not able to give a lot of the details because a manuscript is in preparation, but preparing families to go home and bridging in a well-trained community health worker, a VHT, who is supported, makes a lot of difference. So one VHT said before the home to the facility, the hospital to home intervention, when the parents had a preterm, they were sure that the baby is going to die. But now babies are surviving and the mothers are proud of their babies. Similar things we've gotten from our work in Eastern Uganda, that when you do something, you actually make a difference. So with these case studies that I've given you, what are the policy and program implications? Of course, we are just starting off, but one, I think we need to increase the knowledge about the preterm babies, knowledge about preterm care, knowledge about kangaroo mother care. And it should not just be for health workers. We need to go beyond health workers to the rest of the community, to the public, and also to prepare mothers doing antenatal care and to prepare families and communities. Two, we need to establish a program for community follow-up. We need well-trained community volunteers who are supported by health workers. So that's quite important. We need to use a peer-to-peer model. Those mothers who have been successful in caring for preterm and the preterm survives, we need to recruit them as agents of change to be able to support other mothers. Now, we also need to prepare our community health system. Dr. Nakakeeto has talked about this, including facilities, because either they are going to identify preterm and refer them, they are going to initiate KMC, or they are going to receive back babies, and they need to support breastfeeding, neurodevelopment, and issues like that. So community systems go beyond health facilities. They go beyond community health workers. They include any resource in the community that can be used to improve health. And that can include community groups, can include hospitals, can include churches, can include schools, etc. So we need to prepare them for care of these most vulnerable babies. And the care for preterm is not just a medical thing. It is also a social culture. It is an economic, it is a family and a community issue. So we need a wholesome package. We need to integrate counseling also for mental health in our programs at all levels. And this is a very important call. Preterm care is costly to families. If we can pay for mothers to go and deliver, why can't we support mothers that give birth to a preterm? If we want better outcomes, we've already seen that in terms of neurodevelopmental outcomes, of course, mortality, malnutrition is high. We need to support them so that they can spend enough time caring for the baby. And we need to look at these issues holistically and develop our policies and programs appropriately. And finally, we need to prepare for long-term care. Preterms are meant to be supported for life. Later, even if they became babies, kids, adolescents, even mothers, the long-term effects can be there in all kinds of babies. So those are the things that I wanted to say. I want to acknowledge Chioko and the Adala group. I want to acknowledge our group in the PTBI study and the University of California in San Francisco, and of course the Gates Foundation, which funded us. Ms. Doris Kweska for your work, and Philip Wandul, Ms. Flavia Ziada, who did the costing work, and her supervisors, and Dr. Gertrude and your supervisors. Thank you so much, Mwevale Ino, Mwevale Yala.
Thank you very much, Professor Waiswa. Thank you for taking us from the hospital to the home. Thank you for highlighting some of the key challenges that we face when it comes to integrating preterm care into the systems. I would just like to highlight one key thing that you brought out, which I thought was very exciting, the training to improve breastfeeding, the education about preterms, and the brain development. I would also think and propose that we need to introduce this into the curriculum in the primary schools and secondary schools so that people know that preterms exist. 10% of our babies are born preterm. So you may have at one point in time sat beside a preterm in your class as you were growing up. Thank you very much, Professor Waiswa. I would like to introduce Ms. Tracy Ahumusa, who will be giving her talk on perspectives of mothers, donation of breast milk. Thank you. You're welcome, Tracy. Peter, please unshare your screen. Thank you.
Thank you very much for, thank you so much for having me here. Again, as introduced, my name is Tracy Ahumusa. I am the founder of the ATA breast milk community. I'll be speaking about the perspective of donor mothers. Okay. I'll be speaking about the perspective of donor mothers, especially breast milk donors, really. I am in health communications. I am not a doctor, so I'm really glad to be part of this great panel of experts. I'll dive right into it. So, oh, okay. Sorry, just getting. So I founded ATA breast milk community, basically with a vision to provide equitable access to safely donated human milk to all newborns who need it, especially those who are born preterm or critically ill. We have a mission to provide a platform that supports families in their informed decision to administer safely donated human milk to their infants, following screening, safe handling, and pasteurization. Now, you might ask, what is the Alyssa Marie Foundation? Because I'm speaking about ATA. And the Alyssa Marie Foundation is born from a mother who lost her child early this year, actually. Baby was born Good Friday this year in April. That's April 2nd, and passed away on Easter Monday. And I was the mother of that child. The child was called Alyssa Marie, and this is the foundation that is in her name. ATA is based on her name and my name, which is Alyssa Taha and Tracy Ahumusa. So after this happened, we had known for 6 months throughout my pregnancy that when my child was born, this child would require surgery at birth. And I'm really glad that Dr. Nakakeeto spoke about this, but throughout the pregnancy, in spite of my education, in spite of the fact that I'm in Kampala, I have access to internet, I have access to everything. I did not know that if my child was operated on, that she would require breast milk as postoperative nutrition. I had to find a donor, but I only discovered about this donation option 3 days after my child was born. So, eventually my daughter passed away, and then I had breast milk finally. But I was then given a pill, bromocriptine, to swallow. And I was told this is the only way to do it. It's the most easy way. Just, swallow this medicine and then the breast milk will go away. But this resonated really badly with me, because I thought if this milk is so important, it's so useful, it can save lives, why am I then being given a pill if I want to give this milk to another child who might survive? So I really was unhappy about that period. I was given the pill, the milk eventually dried up, but then I asked around, and a lot of mothers who have lost their babies would have preferred to have this option where they can mother another child. It's a way, it provides solace to give milk to another community. At the time when this happened to me, which was early this year, there was no breast milk bank in the country. And yet we know very well that the WHO says that in the absence of moms on milk, the next best thing is donated human milk from a bank, which we don't have as a country. So I'm getting ahead of myself. So anyway, we started this for the breastfeeding week. We've started a foundation, a fundraiser that we wanted to raise money for a machine that would pasteurize this milk. We didn't want to build anything big. We just wanted to be able to provide milk to just at least, even if it's 2 babies a day, 1 baby a day. And then also we wanted to support these mothers who have no access to breast milk. So we partnered with a few people. A bunch of people came in and they became the core members of Atta Breast Milk Community. We have a lactation consultant who helps the mothers then establish their breast milk. And then we also have a neonatologist who works in Mbale Hospital. This is Dr. Kathy Burgoyne. We have a pediatrician in training. We have a lawyer. Eventually, we got around to registering the company to make it as legal as possible. So that's what we did. And now we decided that due to lack of storage and pasteurization facilities, we would not wait. We would not wait for the Bank of Kampala or the Bank of Uganda, the breast milk bank, to arrive, especially since we know that even if we have a blood bank, for example, we still have people doing what? Reaching out on social media, reaching out on WhatsApp, please, do you have, this sort of blood or whatever? The banks are not always rather available to give blood. So we said, let's start from where we are with as little as we have. We raised some money. We wanted to buy the machine, but we said in the meantime, while we raise the money to buy the machine, this is what we will do. We test mothers for HIV, syphilis, hepatitis B and C. And then in the beginning, we matched these donors to mothers in hospitals because some hospitals insisted on being the ones who tested. We didn't know what they were testing for, but we just gave them we matched. If someone reached out to us saying they needed a donor, we matched them to a donor. But it turns out that sometimes if we match you to a donor, what if I get sick? What if I travel? And yet you assume that this person is going to be able to give you milk for a given period of time. Breastfeeding is not easy. What if I'm struggling with my own baby? So what we did is that we now are the ones who test these mothers. We've partnered with the last digital health expert, which is Rocket Health. They go to the safety of the mother's home. They do not request her to leave her child so that she can go to the hospital to donate breast milk. Sometimes me, for example, I would have been triggered. If I wanted to donate breast milk, I would have preferred to do it from the safety of my home where I cannot see pregnant mothers or babies who would then trigger me. So if you see here, this baby was born very tiny at about 800 grams in Mbale Hospital. But if you see on the left, he is thriving. He was fed exclusively on donated human milk. So this is what we do. We provide breast milk bags. We freeze the milk. It has to be below the minus 25 degrees for about 10 days. We then also provide, in the hospitals, they will teach about pasteurization methods, the simple ones, and ad hoc pasteurization. But we know that this is not sustainable. So that's why we're trying to build the bank, rather the community-based bank. So this is what we do. We get there's a border guy who has a cooler and a fridge. He goes to the family that is providing the milk and then takes this milk to the mothers in need. But consider that this can be expensive because the donor could be in Kawempe, the mother who needs the milk could be in Mbale, for example, but that cost has to be met by someone, and we don't meet it at the moment. These mothers are willing to go out of their way to save their child by providing this breast milk. Whatever the doctor tells them to do, they will do. So these are some of the mothers who have donated breast milk. Someone said, I found out about the community during my third trimester. I made a mental note. that if I had no breastfeeding challenges, I would gladly donate my milk. She's an avid blood group O donor, and breast milk donation was a no-brainer. As you can see, another mother, she felt amazing knowing that her milk is going to help another baby. She says she really finds joy in donating the milk and looks forward to pumping sessions. You can see here, this is someone who has her own child, but she is willing to be on pressure to provide milk for another child. This is someone who lost her child, Patricia. She was also given a pill, and she just wished at that time she had had the opportunity to give this milk to another mother who needed it. She was helping a mother who lost half of her quadruplets, and she kept giving milk every day. She would even reach out to me and say, please, do they need more milk? Thank you for supporting her. I am ready to give whatever I can, and all of that. Another mother, I think, who was basically the first one we had, is that her births were not easy. She has needed blood group or blood ones. The bank did not have the milk. And through social media, she was able to get a donor, but her breasts are always full by day 2 when her children are born. And then she has given this milk. She wanted to give this milk to someone who would need it. And then she made friends with her family. So just like donating blood, she says, breast milk could save lives. So this is what we've been able to do in the past few months. We've raised about 12 million Uganda shillings. This is as of September, because that's the last quarter. We will measure at the end of this quarter. We matched patients within hospitals to donors. And there's about 6 private hospitals in Kampala, but at this point we hadn't included that we were sharing also milk with Mbale Regional Hospital, where the neonatal unit where Dr. Kathy Burgoyne works. And then also we've shared, at this point, this is 38 liters, but we probably shared about 50 liters of milk at this point. But consider that if a newborn baby or a preterm baby needs breast milk, they need about 5 milliliters of milk. 5 milliliters, even just a liter can be about 600 feeds for babies in the Nicu, just 1 liter of milk. So this, we also have specialist doctors within ATA, and also other doctors that we have consulted, including Dr. Flavia Namiiro, who invited me to be here, bless us all. We've also had 24 individual families' babies that we were dealing with at the time. This number has gone up, but this does not include the babies who are in the neonatal unit in Mbale Hospital. We work directly with mothers because hospitals can sometimes be difficult with our donors, and we want to protect our donor mothers. We have about 18 donors approved at this point. And please note, we are being really cautious at this point because we do not want to reach numbers that we cannot manage. That's why you see small numbers, but the need is there, the acceptability is there, and there are thousands of barriers to what we do, but we are determined to get where we are going. So the priority of the people who receive this milk is preterm babies, babies with low birth weight, gastrointestinal complications, metabolic disorders, at all the stages of the process. The milk is free of charge. We ask people to provide milk bags and also pay for the transport for the milk. But hopefully one day we'll have gotten to a point where this is not necessary and we'll just probably have to cover overheads. And then of course there has to be a donor and a recipient. Now, someone already spoke, but I want to reiterate, as a mother who was there, this was my first child. I had no idea about what was going on the whole time. No matter what I asked, they'll tell me, oh, it's okay, it's fine, it's going to be okay. I had a baby who would need a surgery at birth, but my doctors kept saying, it's fine, it's okay. Please, if I knew at the time the questions to ask, maybe I would have asked better questions, maybe I would have gotten better help. And when you go onto a flight, even if you've traveled for 300 times, on a flight, they don't stop telling you what to do if the plane is to crash, right? So even if it's my 5th time to have a baby, no one should assume that I know everything that is going to happen. No one plans to have a preterm baby. No one has to plans to have an underweight baby or a sick baby. So ease of breastfeeding is not automatic or easy, but even when the best interventions have been established, the breast milk may not establish until 36 hours later. Every second counts with newborns and preterms. So, and we know that if more mothers breastfeed and learn about the value of breast milk, they're more likely to sign up to be a milk donor. That is why we support breastfeeding, especially, and also breast milk is one of the effective ways to reduce and rather to ensure child health and survival. Lactation support and antenatal, postnatal support. So during this antenatal period, the golden hour, early initiation of breastfeeding and baby-friendly hospitals go a very long way in making breastfeeding easier. I already talked about what WHO says about donated human milk from a milk bank, which we do not yet have, is the next best thing. And that's why we are doing what we are doing. We're not waiting for the bank. We'll get, when it comes, but in the meantime, we'll do what is possible, because for centuries, milk sharing has been going on. Informal milk sharing is basically, I have milk, you don't have milk, I give it to you. There's cross-feeding or wet nursing. They have been successful where milk banks are unable to meet the need or the demand for breast milk. So mothers are leading in these initiatives, but with little or no support from the public health community. And I urge you, as public health workers, you have a role to play in empowering these mothers to be part of this. And I'm about to conclude. Now, I already said that this is an image of a fetus. And I feel that preparedness is the most important thing throughout the antenatal period and to last about 3 months after the baby is born. Support, support, support. I cannot say that more than enough. I had only just one child. I've never been a mother before that, but I know that if I hadn't, my baby died in April. This is March. We are now in November of 2021. If I hadn't gotten the support that I needed, I would not be able to have started this initiative. Empathy as opposed to sympathy. We have doctors, when my child died, the first thing they told me is that you'll have another one. And this was the pediatrician who was looking after my child without any prior knowledge of whether I had complications or whether anything else was wrong. Empathy, I cannot say that enough. So child loss presents a devastating blow, not only to the economy, but to family, to friends, to businesses, and breast milk can change these perspectives. Medical care, we've already mentioned that informed choice and patient empowerment is very important. The mother is carrying this baby. Do not treat her like she doesn't know what she's doing. If she has access to all the information that she needs during the antenatal period, consider that towards the end of the pregnancy, that is when the baby is at the most risk of coming out. This has to be banged into her head, literally, from the beginning of the pregnancy. We cannot lose mothers, we cannot lose babies, and preterm babies are closer to death than others. My child was full term, and in spite of all the 6 months we had, we were not ready when the time came. There is evidence that also being able to donate breast milk for grieving mothers, but also mothers who have their own babies, is good for mental health. And then we've also said that the more mothers breastfeed without trauma and learn the value of breast milk, the more they're likely to be donors. This is just the SDGs. This is what breastfeeding alone does. No poverty, good health and well-being, quality education, reduced inequalities, sustainable cities and communities. You guys, 6 million, if you're to use formula to feed a baby for 1 year, it costs 6 million. Consider how much that is for a parent who lives below the poverty line. Breastfeeding, breast milk donation are the way forward for a society like ours. This is what we've been doing. We sold t-shirts. We believe that breast milk is liquid gold. We made some merchandise, a few things here and there. We haven't yet got around to doing a lot of these things, but this is the milk we've been sharing. We request that it is, these are the babies that we work with. These are cooler box. That's one of our recipients. That's one of our, those are three of the babies that we've worked with. I urge you to support mothers, first of all, to support those who are breastfeeding, support the community of mothers who would like to be donors. There's a lot of myths and misrepresentation of the value of breast milk, and the time is now. We really cannot afford to do, to wait for anything other than ourselves to do this. And these are our little babies who share their mother's breast milk. That's Zion, Noel, Jahid, and Anaya. Thank you so much for having me. We are all over the social media platforms. You can follow us there. And yeah, I'll answer questions later. Thank you very much.
Thank you, Tracy, for such an awesome presentation. I think one thing that I would like to share with you, and I hope you'll be happy, is that your breast milk bank is soon going to happen, very soon before this year ends. So I hope that is something that will make you jump out of your seat. But just to highlight some key aspects of what you have mentioned is the issue of milk sharing. I remember vividly when I was a bit young, my grandmother used to do wet nursing. And every time when I grew up, she kept telling me that this is your auntie, even though this child came from like 3 houses away, she would tell me that this was your auntie. So it was a concept which I think we have done in the past, but just to move forward for the safety that you're talking about. So Richard, I would like to request that we take a few questions and answers before we move on to the last 2 presentations. And I would like to kindly start with Professor Waiswa. There were a few questions sent towards you. Please, if you could unmute and answer in the Q&A before we go into the last 2 sessions. Thank you.
I'm not sure which particular question, but one was how is brain development done in the Chuoko? Do you have any other question?
I think you answered it on. They asked about the presentations.
Yeah, one was on the presentation. So what we have done in the Chuoko, of course, the whole thing with brain development starts into a pattern if you are able to do good antenatal care and then a safe delivery care. And afterwards, what our presenter from ATA has been talking about, the care after, including breastfeeding and the support, including preterm care and the avoiding complications. But actually, we've taught both mothers and also the community workers and the health workers are able to be trained on how to stimulate a baby and also to be able to do basic neurodevelopment assessments. So I'm not able to go into all the details, but a lot of it is around how you stimulate your baby. One of the things that we found is that, which is also work from Dr. Gato Namazi, is that in our communities, especially in the villages, but also it's changing. We need to do actually these studies on early child development, even in urban settings. In the communities, parents don't stimulate babies as much, don't play with the babies. Babies are abundant. In the towns, they are being given toys. And even so-called early child development centers, schools, we actually surprised that they know very little about stimulation of babies. So there is a lot of gap in our communities that we need to be working on in order to make babies more responsive. I'll leave it at that for now. I think the others were mainly comments. Thank you.
Thank you, Peter. Tracy, you have a handful of questions, but I would request you to pick some that you have not answered in your presentation. There was some about the process of collecting the milk and testing, which I think your presentation answered, but please go ahead and tackle a few on the Q&A. Thank you. Over.
Thank you, Mr. President. I'll quickly ask, I was inquiring, the first question is, I was inquiring if there's an NGO government, no, that's someone else's question. How do mothers pay for this milk? I think I already answered that. The milk is free of charge, you pay for transportation. We believe that milk, like in Senene, is naturally occurring, except that you probably have to pay. That's probably not a good example, actually, because in Senene are expensive. So how does one sign up to donate breast milk? We have numbers. We have, at the moment, I have my number. Maybe I'll share it afterwards, or they'll share it. And the number to the community is what I mean. And we help you through the donation process. How another person asked is, how do you ensure the safety of breast milk without pasteurizing? We pasteurize, it's just the ad hoc method of basic water heat treatment. We do not do this because I am not an expert, but we share the milk with people that know how to do it. And mothers who are receiving donated breast milk are already trained on how to heat treat the milk without endangering the nutrients in the milk. Now, if a mother wants to donate, I have already mentioned that, we will share a number. How safe is this donated milk to vulnerable babies? Safety in terms of quality, storage, HIV infection still at large, and then which class of women can afford this? This is a question that I'm sure has flagged a lot of people. HIV, and I'm sure one of the other doctors maybe will speak about it, but I'll talk from the terms of, from where I stand. We test the mothers for HIV, syphilis, hepatitis B and C that may be transmitted through the milk. But we also pasteurize the milk. So the important thing is that with that extra heat treatment, we believe that the milk will be safe for the babies. And there's evidence that this has worked for many years. At the time when HIV started, breast milk banks were actually there, and then they ended up stopping. But I'll probably ask Dr. Flavia or some other doctor to explain this properly. We know it's working. The neonatologists we work with are doing it, and there's evidence that supports breast milk sharing and even breast milk donation from a milk bank. The informal version is also supported. Dr. Tracy, I'm not Dr. Tracy. Are some special consideration? Are there some special consideration in terms of nutrition, the donor mothers that we should be cautioned about or not? Yes. We also make sure that you can only donate within a specific period of time. There is a screening that you do to ensure that, first of all, your house is not a tobacco consuming household. You answer questions on, first of all, spousal consent, because we've had incidences where mothers sign up to be donors and then their partners, their husbands say, no, don't give out milk to people. So we get questions such as spousal consent, your history in terms of medical health, your medical health history, your potential medical health future. That is, are you at risk of getting HIV or STDs or all of that? All of these tests are done, but also the screening is done. This is a risk versus benefits approach that we do. If we do not do this, if we do not show the proof of consent, in the meantime, babies die. So if we can solve this problem and learn from where we are willing to go. Yeah, I'm sure we'll be able to answer other questions personally.
Thank you very much, Tracy. We have two hands up. Daniel, can you please unmute, or Richard, give him permission to unmute and he asks his question. Daniel, your hand is up. Please unmute and ask your question. Okay. Olivia, Please unmute and ask your question. Your hand is up. Daniel Wambuzi, please unmute and ask your question so that we don't lose time. Okay.
Do you think people are able to unmute, or they need to be unmuted by?
We have allowed them to unmute. That's why I'm asking them to unmute. We have given them permission to unmute. I hope these hands were not placed by error. All right, so I think the Q&A session is over. We're going to move on to the last two presentations. I would like to invite Professor Romano Biaruhanga, who is currently the board chair of the Maternal Specialized Women, the Mulago Specialized Women and Neonatal Hospital, to please give his talk on training and deployment of health workers in neonatal care. Professor Biaruhanga, you're welcome.
Hello, good afternoon.
Good afternoon, we can hear you clearly.
Yes, I had sent my presentation to Richard. I hope he has it. Could he put the screen on?
He is actually sharing it as we speak.
Okay, thank you very much, and for inviting me here. The topic I was given was a bit of an odd topic, and it was training for service delivery in neonatal care. Is it important to prioritize a person's interest and expertise before deploying them in the health system? So it was an odd section. So I opted to look at it as I put on two hats, one as a health provider, both working in the private sector, and but also as a person who also contributes to issues regarding governance and policy in public facilities, but also working with various institutions, especially Ministry of Health, with regard to policy formulation. Next slide, please. That's going to be my background. Next slide. Could I have the next slide? Richard. Richard, you have gone very fast. Could we go to the third slide? Yes, globally, this is information that all of us know. Globally, we have about 2.6 million newborns and 2.6 million stillbirths. And of note is that our under 5 mortality rate has globally decreased since about 1990. However, 46% of under 5 mortality is the manifestations of death that occurs in the first 28 days of life. And in Uganda, our neonatal mortality has sort of stagnated. And out of these figures, really out of the 10 countries with the highest mortality, especially of under 5 and neonatal periods, are actually in Africa. Next slide, please. These are some of the trends in maternal health, and based on UDHS 2016 that we all know. Next slide, please. And we do know that in our setting, the 3 commonest causes of our deaths in the neonatal period are preterm deaths, intrapartum complication that usually results in asphyxia, that's really a manifestation still of the challenges of obstetrical care in many of our settings, whether it's at community level, but mainly also at health facility level, where they are delivering at health center 3 and above. And neonatal infection contribute literally up to 87% of all deaths that occur in the neonatal period. Next. And these are the challenges of newborn care that we all know. One, we still have a knowledge to gap policing. We have done a lot of research over the years, but at times some of the research that we do will not implement at policy level. There's poor financial accountability, life-saving products are still inadequate, accessibility, poor utilization, even of what we call essential existing interventions that have been proven globally and within Uganda to work, and also issues to do with monitoring and evaluation. So from the perspective of a health provider, whether I'm specialized, it's important to know that when you become a specialist, or whether you're a health worker in whatever cadre you are in, you're coming into a health system that is working but struggling to provide services in an appropriate manner. So when we're looking at priorities, what is actually a priority? It's really a process for addressing the most important health needs as highlighted in the health sector situation analysis in the context of the fact that we're in Uganda, where we have limited resources, and many of these limited resources are competing. And at whatever level you're in, whether you're in a management level, whether you're in a clinic level, whether you are a single midwife managing a maternity unit, at times choices have to be made that reflect what is needed most from the situation analysis that you have done. But at policy level, choices have to be made to reflect a society's values and vision for the health system. And a health system involves all of us, and it's complex, including that of the health provider. So if I'm a health provider, in as much as I may have needs, I need to always reflect whether my needs are tallying the needs of the society or the group or the institution that I'm actually working for. Next, please. Why and what do we prioritize? Whether it's at family level, but I will now talk it from a health policy level. We prioritize because we have limited resources, and we try to address the community or the citizens' health needs and demands as identified through a situation analysis. As much as possible, we hope that the needs and demands should be evidence-based, cost-effective, and as all the presenters have been saying, equitable, so that we have equity addressing the health needs for all population groups, even the most vulnerable and the poorest in the different segments of our society. So the situation analysis generally, whether we're at institutional level, guides our strategies and possibly our limited resources in the public purse. And it's important by whatever analysis that you do, we are prioritizing, that the M&E component is highlighted. And M&E component at different levels, whether at Ministry of Health level, has always been a weakness when we come to strategic planning and when we come and look at our different policies that have been produced over the last 40 years or 36 years. Next, please. You are a health worker, but there are many other players when we are doing priority setting. At most, we have policymakers, health planners at Ministry of Health and other ministries, especially Ministry of Finance, and Ministry of Planning and many others. We're never an island, and we always need to remember that. In as much as we try to drive our needs, we're never an island, whether we're at an individual level or whether we're talking as a group of doctors or a group of society, we are not an island. Other priority members who set priorities are administrators and health authorities at decentralized level, and in Uganda we have so many districts. Health professionals are key both in the public sector and in the private sector. And a key note are the stakeholders in the community where this care that you are striving for is actually going to be placed in. Next, please. So how do we balance the priorities of a health worker, his expertise, and his need to be deployed vis-a-vis the society? The way I would answer that question is that when a health worker comes in, he or she needs to know, as I had said previously, the challenges of the health system and what he or she does or the oath that she takes. And that person is really never an island, but is part of the community. And in most part, the community's needs takes precedent as compared to an individual's need, no matter what the expertise that you may have. Next. And because of that, we have strategies at global level that were based on evidence, and these are strengthening and investing in care during labor, birth, and the first days of life, where we know most neonatal mortalities occur. Strengthening of the health system to optimize organization and delivery of care. Universal access and trying to reach out to every woman and newborn by minimizing equity to access and coverage of care, which we're still struggling in Uganda, so that we can have universal health coverage for everyone. Harnessing the power of parents, families, and communities, as Professor Peter said, and improving in data collection so as to improve on our decision-making and accountability. Next, please. And these are evidence-based interventions that we know and that over the years and through many researches have shown to have high impact: antenatal corticosteroids, antibiotics, kangaroo mother care, cord cleaning using chlorhexidine, inducing hypothermia for patients who have severe asphyxia, and community-administered antibiotics. Next. So the main causes of newborn deaths we know have effective and feasible interventions. And these are some that we care for. But as we had said, that although we know these interventions, how they are being implemented at different levels of community is still a challenge. So outwards there, we have several interventions that we know are evidence-based, but still we are still having problems in how these interventions are being implemented and supported. Next. So overall, in order to decrease deaths and in order to decrease morbidity and mortality, especially of preterm, we know we need to have a combined approach for multiple interventions. Constantly stimulate to have simulated-based training, feedbacks, teamwork drills, clinical mentorship, please, audits, QIs in health facilities. These over time improve proficiency on neonatal care and resuscitation, and increase in health workers' knowledge skills in maternal and newborn care. Knowledge is continuous and knowledge is never complete. So we keep on learning. As somebody said once, that you really stop learning maybe 2 hours after you have died. Life is such that you continue learning and you always have to update yourself in as much as you may be a good specialist in whatever field you have. A key driver now is enforcing issues of clinical mentorship to reinforce knowledge as well as skills, especially for frontline health workers involved in emergency obstetric and newborn care provision. Next, please. And this is a framework for every woman, every newborn, every child, looking at the continuum of care so that quality of care with aspects on looking at health workforce, commodities, health information system, community empowerment, and looking at aspects of governance, partnership, financing, and proper accountability. Next. So way forward is that we need to look at all these factors. In as much as I'm an individual who needs to prioritize and I have ideas of what I really want to do, you always need to remember you are part of a society and part of a community, and at times your community's needs far outweigh your needs. Way forward, we need a sector-wide approach that is still being empowered on. We need to concentrate at the time of birth, immediate post-delivery and care of the preterms of small for dates. We need to struggle to have universal coverage. We need always to look at the care that we give at health facility as we increase more mothers coming to deliver at health facility, literally clocking up to about 74 and above. We need to strengthen our health system. We need to constantly have integration with the community where proper follow-up of the newborns and especially of preterm is key. And the whole aspect of leadership accountability and always contextualizing the interventions that we do is key. Thank you. Last slide. Thank you very much.
Thank you, Professor Romano, for your presentation. I will not even summarize because you ended with an excellent slide highlighting the key aspects that we need to move forward. I would like to now welcome our Commissioner for Reproductive Health, Dr. Jessica Nsungwa, to please give her presentation on the next steps, Ministry of Health, commitment and policy. Thank you.
Thank you very much for moderating this session. And I also want to thank the Women Hospital for hosting this meeting for us as a tradition. I think it's going to last. Last year we're here, some of us, and we're back here. But also to thank the organizers, especially our partners, but also the team from the Ministry of Health, and more so the experience we have had from the people who have gone through this. I think you've put a face to this webinar, Tracy. I want to thank you very much for your presentation. I was requested to talk about our next steps for a better outcome. And my presentation has two things in it. It has a better outcome for preterm and the next steps. And I was seated here when I was listening to all the presenters. By the way, thank you very much, because most of you have actually touched on the key issues we want to look at, or probably where we need to move. I was just wondering, what is the better outcome in all this process? Is it survival? Maybe yes. I think we need to have these babies survive. You've listened to both the technical people and the lay people. But I think with the Sustainable Development Goals, the challenge is even bigger. We are not only concerned about how these babies survive, but we're also concerned about their well-being. What type of babies are going to survive after all this process? What type of future do they have? And what will they contribute to the next generation? So our scope of next step and outcomes rather is now even a bigger challenge, because you can see that not only are we going to count deaths or people who survive, but we also need to have clear measurements or indices to follow up these babies to understand the outcome, because as we have heard from the presenters, more and more babies are surviving in this country, although the prematurity rate is rising, but more and more babies are surviving, especially including the extra small babies. So that for me was a very important thing for us to start thinking. But also, even if we think about, as we move to think about the outcome, we have a lot of unfinished agenda from the previous MDGs, as you may have seen. Currently, prematurity is actually our #1 cause of death in the first 4 weeks of life, but also the second cause of the mortality in the under 5s. Pneumonia is #1, and malaria has shifted down now. So prematurity death is a big problem. Babies born too soon are going to continue being a big issue for us to discuss. So I'll just take you through some few issues, and most of the issues are actually linked to what has been presented. I like the program, but it tried to move from many angles of the problem, but also the fact that we had the perspective of the mothers. So what is our thinking and what are we driving us at in the policy? The first thing by the way, currently we are now reviewing and developing a new sharpened plan. And as you're well aware, that newborn health, and including premature birth, is a central piece of the whole package. So we've been having a dialogue and discussing, and I'm going to borrow some ideas from what we've been talking about. And I'll begin with discussing the approach. The approach will still remain a dual track. We are focusing both on prevention, and we need to accelerate prevention because we believe that through prevention, we'll be able to deal with the inequities. If there's an age group in our life courses in maternal child health, where inequities are very clear-cut and stark, I think it's the area of newborn health is one of the areas where when Waiswa presents his slides in some of these workshops, when you break down these age groups, you'll find that the newborn health, that is where we're actually experiencing a lot of inequities. And we believe that if we're going to close these inequities, we need to accelerate our interventions for prevention for the preterm birth. We are lucky now, we have also learned, and through our initial experiences over the years, especially since 2012, that actually we can save these new babies. And I want to appreciate the innovations which have been shared, but also to appreciate the discussions on the quality of care, which is also our important new area of focus, that actually it's possible to save these babies, but we have to make sure that moving forward, we also care and think about how these babies will look like when they come out of our hospitals. So the issue of inequity would mostly be addressed by prevention. And we have a lot of interventions or focus in that area, including the issue of family planning, which is a big problem because we know that multiple pregnancies, too frequent babies is one of the biggest problems, but also malaria and nutrition as key areas of focus to prevent these premature births. But we also know that a big proportion of these births cannot be explained, and we need to do more research. We need to do more local understanding, including studies which have been done by the Waiswa Group and the University of California on understanding the role of stress. The role of stress as a contributor to preterm births is becoming more eminent, and we need to understand our local interpretation on what stress is exerted. So we need more research on some of those aspects. We have also discussed and decided in our policies when we want to do these interventions and where we want to focus. And I think Dr. Romano has also intimated on this. Most of the deaths and the problems which occur among this special age group occur during labor, during the time of childbirth, and immediately after, the day after birth. And you find that actually more than 75% of the deaths will occur in this time. We've learned from Saving Mothers Giving Lives that actually this works and we can get more benefits, and we want to invest more here. And in our investment case, it's very clear that we want to put all our strength around the time around birth. Although I have also mentioned that prevention is a very big focus in our plans and in our priorities. So what do we want to do? We want to make sure that there is high coverage of high impact interventions. My colleagues have talked about kangaroo mother care, one of the most evidence-based interventions we've seen in countries like Malawi, what this has done to reduce the number of deaths. But we have also known that for Uganda, kangaroo mother care is an old intervention, but it's also one of the interventions which is very thin on the ground. And we're working with the World Bank project and in the department to see how we can actually scale up this very cheap, very cost-effective, and very culturally appropriate intervention to do KMC. We also have several innovations, and I will not touch on them, but I want to talk about the issue of corticosteroids, again, which is an evidence-based practice, which you see actually even in Kawempe, when you sit in the meetings when we're discussing issues of mortality and how we could have avoided, you find that many children who could have survived because as a result of having received these corticosteroids to be able to improve, to accelerate the development of their lungs is actually not provided. And this is an area we want to focus on a lot, including making sure that we report on this and make sure that the commodities are also easily available. But our health workers are confident and skilled to give these corticosteroids because many more babies can actually survive and give these drugs in time. So we want to make sure that these interventions, these well-known interventions, are actually scaled out nationwide. We've talked about the NICUs because the NICUs are going to support us to save these very small babies. And we've started seeing many of these, even babies as low as 600 milligrams survive, and they pop up in different parts of the country, including the rural areas. We see babies come up and they survive. So we need to make sure that we expand the scope and make sure that these babies also are surviving. And that's why the Ministry of Health is now putting more investments in NICUs. We are also looking at the issue of continuum of care. Like I said, these babies will survive, but we need to follow them up in the community. We need to make sure that there are setups and systems in our structures, including health workers, who know what to do and they know what to look for, but they also need to know how and where to refer. So, and this brings us to the discussion of the neurodevelopmental issue. I think this is one of the biggest issues, which is where we're going to need to develop more capacity and maybe invest more. Peter has talked about stimulation, psychosocial support, and the whole dyad of the mother and the baby to make sure that as they go through this stressful moment, this moment which probably was not expected, they are able to support the babies, but also the families are supported, and especially the mother, that this baby is able to get to develop to their full capacity with all these interventions, which could be done in the facility, but also in the community. The other area of focus in terms of policy is the issue of how we deliver our interventions. And here I think we have emphasized the need to give the right care at the right time and the right place, which is basically the quality of care, which matters in addition to coverage. And we need to invest more. I'm glad that over the years, post MDGs, that the quality of care has become a main issue. Previously, it had fallen in the cracks, but there's more emphasis and more understanding, but also this deserves a lot of reorganization of the healthcare system. I want also to mention that we are expanding beyond the clinical quality of care, but also looking at the human rights approaches and perspectives, not only to survival, but also to the well-being of the baby. And we're struggling with discussing what will it mean to discuss and intervene and have interventions for the well-being of the newborn baby. We're looking at issues of respect and dignity. How can you provide services to the newborn babies which are respectful and dignified? And also the issue of non-discrimination. So respectful maternal care is one of the areas we are looking at, but also respectful newborn care is also an important side of the angle of the discussion. And we have indicators which are coming up, but also we have a global alliance or steering committee, which is looking at these aspects. And we are also seeing more legal issues also coming up. And I think the issue of human resources in maternal newborn care is becoming a problem right now. As a department, Ministry of Health, we have petitions which we are discussing in court, basically because we do not observe the human rights approach aspects of the maternal care. So who are we trying to target? Who are we putting new emphasis now? We are making sure that we are reaching these mothers early enough and want to reach every girl. We've developed frameworks, multi-sectoral frameworks to be able to reach every girl, an adolescent girl, but of course knowing that behind the girl is always a boy. And we're looking at every woman, every newborn. And I think Dr. Romano shared the framework which we are using, but also making sure that we are looking not only around people who are easier to reach, but also the poorest, those who are overburdened, to make sure that we also implement the universal healthcare coverage, but also the commission, the Lancet Commission, which was disseminated by UNICEF and WHO. So we want to make sure that we are reaching the most burdened, the most neglected, and the age group which contributes most to preterm births, many adolescents. And I think this pandemic has now shown us that we need to have systems for young girls. We need to have systems which can protect these young girls in our communities, but also when they get pregnant, we need to make sure that the services are easily accessible, because many young people are likely to have their babies born too soon. The issue of people power, I don't think I can overemphasize this, the role of families, mobilizing people for change, building a movement and having a broader plan, which will encompass more people beyond the clinical workers, but also other people who support the system to make sure that these babies are able to survive. We're talking about breast milk banks, we're talking about other inputs, nutrition, diet, and so on. All these are required, including sectors like water for hygiene purposes. So we need to have a broader plan, and we are thinking about casting our net more widely, but this means that we need to engage more people. We need a framework and a system which can engage more people, initially sharing information, but also making sure that there is a meaningful engagement. We want to count and measure, and I'm very excited that if there's anything we have achieved since our campaign in 2012 when we made a commitment, it is so exciting to know that now we are able to count these babies. We still need a lot of work to do here. We need to do more surveillance for preterm birth, but increasingly we have data for planning and programming. And this is very important because without the data, we can't plan for them, but also we can't account for these babies in the system, but also in terms of the duty bearers, what they have done. So this is one of the areas where we have advanced. We are also swimming in the data reform, which is affecting all countries globally. But I think this is an area where we are making some mileage, and I think it's a core piece for all the policies we are going to plan and do. We are also giving some specific attention. Okay, specific attention to some policies which we think are contributing or would support these babies, the issue of maternity leave, both for paternity and maternity leave. In other countries, you have mothers actually able to get maternity leave for as long as 1.5 months. And I was listening to Tracy and the issues she went through both when she was delivering and post-delivery. And I was wondering how much time would she have required, suppose she was working, to be able to overcome some of these things, but to make sure that she's also be able to reinstate herself into a normal system, including being able to go to work for work. There are issues of the KMC, I think I've talked about that one, but also there's a policy on birth and death registration, making sure that we are able to count these babies, but also are able to report and count all the deaths, including those who die in the communities. If there's an age group which dies in the communities more than the facilities, it's most of the newborns, especially when they are preterm and they're very small. They are not counted. Even their graves cannot be found. If there are any grave, they are dug over and you won't find them. If they are there, they won't even be labeled. Even the mothers will never remember them. So we need to improve data on birth and death, and also teenage pregnancy. Our policy on teenage pregnancies, child marriages are very important, family planning, and as I said earlier on, male involvement. These important policies affect this age group very indirectly, but they're very significant. We also need to have the political will. We need to build the momentum. I'm glad that increasingly we have champions, and shortly I'll be talking about our pioneer champion in this country. But I want to thank that we're increasingly actually seeding more champions. Previously, when we started, there were very few voices, but we are seeing much. But we need to take this process further. We need to take it to Parliament. We need to take it to the other organizations. We need to take it to the labor force. We need to take it to the private sector and actually make sure that this movement is pushing for more investment for these very voiceless babies, and make sure that at the end of the day, we are able to manage and the system is capable of managing. The other aspect is the social protection. We have a number of programs in the country which are able to support mothers, especially, but there are fewer programs which are supporting children and babies, including adolescents. Mothers who cannot afford to pay for care, mothers who cannot afford to go for diagnostics like scans, mothers who cannot afford even to go for transport. We need to broaden these criteria for these social protection programs to make sure that babies like these ones are actually very significant, and even expand them and extend them beyond the first few weeks after delivery, because these babies have a long-term consequences and may need longer-term follow-up. So we need to look at some of these things. And lastly, the issue of working with other sectors. I have mentioned here the sector of WASH, but we also have other sectors like gender. We have sectors like agriculture for food security purposes, and so on, and including finance. We need to have more players come on board and assign duties and be able to do accountability mechanisms to make sure that people are committed and they're fulfilling their pledges, including the academia. I'm glad that many of the medical training institutions are now onto this, but I'm not very sure how much we have invested in other paramedical trainings, including the midwifery and nursing areas. We have now introduced a newborn fellowship program, but we need to make sure that we are scooping more people, but also decentralizing these trainings. We need to get the paramedical workers in this process, the biomedical engineers in these processes, so that we have a fully comprehensive system and players in this system. So Ministry of Education has to be very central in this process. So some of these things are some of the things you'll be seeing, which will be unearthed in our new plan, which will be launched very soon, in terms of how we can support, in terms of creating an enabling policy environment for premature baby, for preterm births or preterm babies. I want to stop there and thank you very much. But before I stop, I want to request that we observe a moment of silence to remember our old pioneer neonate, Dr. Gelasius Mukasa, who passed away, unfortunately, during the pandemic. Many of us were not able to attend his funeral, even know about his death. But Dr. Mukasa was a pioneer for this area. Actually, we had nicknamed him as a neonate. He chaired the newborn steering committee for more than a decade, but also he ran the special care unit in Mulago National Referral Hospital for a number of years. And I would like us to give him a moment of silence before I conclude. May his soul rest in peace. Thank you.
Thank you, Dr. Nsongwa, for the highlights and the motivation around the areas that can help us improve newborn care and overall care for the child, for the mother, and also improving the quality of services which we render in our country. I would like us to have a few questions. Richard, can you please allow Waswa George Muganwa to ask a question? And then after that, we can have a close, and I'll hand over to you.
Thank you very much, Mr. Moderator. I have two questions for my colleague, Senior Consultant Professor Romano. Dr. Romano, we have two problems. One of the problems is low-skilled birth attendants in the rural areas. For example, we know that more than 70% of all obstetricians are in Kampala. So in the rural areas, some areas which are country and difficult to reach. Some of the problems are low social amenities, schools for the children of the health workers, entertainment, professional progression, of course, something to do with side income. And despite the government medical officers in Dr. Romano, what are your thoughts on these problems? Is this what's happening? What are your thoughts on the solutions? And the other question is, we have been doing a lot of trainings and supervisions and skills workshops, EMOC, CMOC, BMOC, so many of these things. But still up country, we find there's still low knowledge and low skills. What could be the problem in your opinion? And what can we do? You are now both an administrator and a health provider. Of course, we know one of the things that we could do is low dose, high frequency, but this also has its problems of cost and of course the manpower. Dr. Romano, what are your thoughts? There may be no straightforward answer to this, but we need some thoughts to solve this problem. Thank you very much.
Thank you for the question. Professor Biarohanga, the question was specifically to you. I would request you to try and summarize some answer, which I know could be the whole day, but please go ahead.
Thank you very much. Dr. Waswa is our senior colleague, and he has been very instrumental in the field of obstetrics, especially in the field of obstetrics, and obstetrics is so linked up with pediatrics, and especially with the newborn care. Along the way, part of the question muffled up, but I'll try to answer what I could hear for you. As I said, medicine is so diverse, and we need to really appreciate that all of us, even at the level that we are in, some of us have been in practice for 30 years, we keep on learning and we keep on undoing certain practices that we had acquired or were taught many years ago. So I think anyone entering literally any profession needs to know that CMEs, or continuous medical education, is a continuous process, provided you are still practicing in the field of interest that you are in. So the aspect of saying that we have been training and we have been supervising, yes, we have been doing it, but we need to know that it is really part and parcel of the trade that you need to keep on getting information, and especially improving on skills, because medicine, especially clinical practice, is an apprenticeship. Your skill set goes if you do not practice certain things. If I do not practice neonatal resuscitation, over time, if I've not resuscitated a child for 6 to 1 year and I get a newborn, I most likely will not resuscitate that particular person appropriately. So skill sets, especially clinical practice, requires continuous drills, continuous revision, continuous mentorship processes. Please remember that the M&E section, especially the monitoring and support supervision, and Dr. Jessica can comment about this, over the years had sort of weakened. And in the last literally strategic plans, 2, 3, there was a lot of emphasis to bring back and to strengthen the aspects of mentorship, support, supervision as a way and as a strategy of reinforcing quality of care at facility level. Low skills birth attendants, yes, they're there, but because of the difficulty of assessing quality of care and the fact that strategically government placed and has emphasized a lot of improvement in women having their deliveries at hospital, most of the emphasis, as I said, when you're looking at priorities, you'd rather prioritize and influence the community to try to come to a health facility where you are assured of the cadre of the health worker that you have trained. And that has improved over the years. So the key emphasis is that the cadre that we have at the different health facilities, let's say from Health Center 3, where we started having basic emergency obstetrical newborn care and upwards, is capable enough to cater for the common problems that occur both in obstetrics and newborn care. So that possibly within the next 5 years, if our skilled birth attendance goes up to about maybe 90%, some of these problems that we're having, I think we will start seeing some better indicators improving. With regard to the health worker, it is true. It's not only money that drives the satisfaction of the health workers. So at policy level, when you're talking to people, especially the young people coming in, a young person wants to be appreciated in whatever institution he or she is working, at whatever cadreship he or she is, amenities, especially in terms of transportation, accommodation, and especially in terms of that institution being able to show him that he has a path for career development. It's not always money that really counts, but the other aspects of amenities that combine to make somebody's satisfaction in where he or she works better. I hope I've tried to answer your questions, Dr. Waswa. Thank you.
Thank you very much, Dr. Romano. Indeed, you have.
Thank you very much, Professor. I would like to, before I hand over, I would like to thank all members who have joined us in this session, all our presenters, and also to remind everyone about the World Prematurity Day, which will take place on the 17th. And our color theme is purple, so please look out for your purple outfits. I would like to hand over to Richard. Thank you. Thank you to allowing me to moderate the session.
Thank you very much, Dr. Deo Munube, for moderating the session. We thank you, our panelists who have set time to be with us this afternoon and have given us some very wonderful presentations for the commemoration of the World Prematurity Day for this year. As Dr. Deo has said, we are commemorating this day on the 17th of November with celebrations in Kasese, where we'll have a number of health workers and health facilities, as well as partners who have supported the work of newborn care across the country, awarded with certificates of recognition. So if you're able to join in physically, you're welcome to Kasese. And I hope there will be also provisions for a virtual link. The presentations and the recordings will be shared to everyone who registered for this webinar. Just look out for an email from National Safe Motherhood. That is nasmecug@gmail.com, or check on the YouTube channel where we upload all the presentations. Thank you so much, and I wish you a good evening.